Good afternoon. I'm really delighted to moderate this extremely complex panel because the question is the component of a good health system in Africa. And we have here good people. They will introduce themselves. And I'm also happy to see that the panel is balanced in terms of gender. We have two great ladies and two great guys, very experienced one, who will share with us their view and the different component of a good health system, at least for the future. This panel is in the frame of the AFSIC. It means that we will have to convince you that in the mind of each and every health stakeholder in Africa, health is not any longer a cost, but an investment. And I count on the panelists to confirm this position and this assessment. So let's introduce. Let me ask the panelists to introduce themselves. We will start with Dorothy Masiki. She is the group head of risk and compliance at ICL Lion Group. Dorothy, to you.
Thank you very much, Karim. Dorothy Maseke. I work for ICL Lion Group. We are a one-stop shop for insurance and related financial services, headquartered in Nairobi, Kenya. We have interests in two other countries, that's Uganda and Tanzania. And we provide products and services in insurance, in pensions, in investments and trusts. And very happy to be here today. Thank you.
Thank you, Dorothy. And now, Evelyn.
Hello, thanks for having me. I'm Evelyn Castle. I started my career in the NGO sector. I founded an NGO called eHealth Africa. Then I moved to the private sector and started a for-profit primary care company called EHA Clinics. And now I'm in the investment sector. So I'm happy to be here today and talk about all those different areas.
Thank you, Evelyn. Gitinji, my good friend Gitinji, I will let you introduce yourself.
Yes, hi Karim, nice meeting you, Evelyn, and Dorothy as well, and Gazi. And my name is Dr. Gitinji Gitahi. I'm the Group CEO for Amref Health Africa. Amref Health Africa is Africa's largest health development NGO, which is working in about 35 countries in Africa, and but also has offices in Europe and North America, but is headquartered out of Nairobi, which actually makes it very unique in the work that we do in the continent. We are an organization that works at the interface between community and the health systems. My background is I'm a medical doctor, have been in business. I worked in the media, worked with pharmaceuticals, and also worked in insurance, Dorothy. I worked in Madison Insurance for some time. So I look forward to this conversation, Karim.
That's great. Gazi, the man of the continuous
Hi,
medication.
Hi, everyone. Yeah, my name is Gazi Dargouth. I'm president of THA, Tunisian Health Alliance, which is a consortium of a Tunisian company working within the healthcare sector. And I am also CEO of School of Training for Healthcare Workforce. We launched this company about 10 years ago, and we try to really ensure that most of the healthcare workforce are really trained. So we'll be talking about that later on.
Fantastic, great. Myself, Karim Benaw, I'm a bit like Gitinji, medical doctor by training and a surgeon. And I've been working for the pharma industry the last 20 years, since 2000, and mainly for the Merck group, where I had the pleasure to act as an executive vice president for the African operations. And I also I enjoyed it, and I had the pleasure to open more than 7 affiliates in Africa for the group, which was not an easy task in early 2000, but at the end of the day, it was an amazing outcomes. I'm actually chairing also the Africa Engagement Committee at the level of the IFPMA, and the IFPMA is the association of the pharma industry, the biopharma industry manufacturer. It's based in Geneva, and we are trying to really to make sure that the industry is doing the right things in shaping a great, solid health ecosystem. So we are involved in policy in the COVAX program. We are involved in also several other activities fighting counter falsified products and so on. All the big issue that we have in Africa. So, as you may notice, this panel is people with experience in for-profit and non-profit organization. So it's amazing. We have this double hat, and this reflects really that we are really mature today to cooperate with public sectors, with non-profit organization, and we do understand that the private sector is not the issue and the problem in terms of health system. It's part of the solution. So let's see that, and we start with the primary health system, because without primary health system, we can do nothing. This is the arm, the arm of any health system. So Evelyn, up to you.
Great. So I feel like this is a difficult task to try to convince you to invest in primary care. If it's possible, I did put some slides together, but it's saying that I don't have the ability to share my screen. I don't know if that's possible or not.
Maybe
great. They just gave me the option. So, like I said, so today I'm going to talk about primary care and why I think you should all invest in primary care. And because I'm sitting here in Nigeria, I do focus on the Nigeria market. And I like to start with numbers just because I do think that sometimes we forget, or you know, the numbers are just so huge that I do think that they help kind of set the lens of what we're looking at. So Nigeria, you know, we're looking at about 206 million people right now. In 2050, they're estimating 400 million people. We do expect life expectancy to increase. And right now, sub-Saharan Africa is really the only continent that's looking to have rapid population growth. So we know the numbers are there for a great market. And again, I mean, we all are sitting here knowing what the health indicators are and how big the challenge is of primary care in Nigeria. But, you know, looking at the right there, you can see almost all of these main causes of death could be solved in the primary care market. So if you're looking at really having the biggest impact, primary care is where that's going to be. And then here's where I think most people care about. These are the numbers. The estimated private healthcare spend in Nigeria last year was nearly 14 billion USD. And I think the numbers that are really interesting are the amount of medical tourism that is happening outside of Nigeria. People are going to Egypt, to Dubai for medical tourism. And, you know, across just Nigeria, that's a $1 billion market that we're losing each year. Because we don't have the capacity in country to do some of that. So I use my company, EHA Clinics, as a little bit of a case study. to talk about the fact that primary care is profitable. Right now, we see a lot of investment coming into Africa in, like these specialty hospitals or in pharmaceuticals. But I do really think that there's a great market for investors to come in and actually invest in primary care. And obviously this is one example, but there's tons of examples of successful primary care companies across Africa. So EHA Clinics, we're still a very young company. We have 4 operating locations in Nigeria right now. We are a membership plan, so we have about 2,000 individual members at the moment. We do focus on COVID-19, which has been a huge profit center for the company. And we're about 130 individuals at the moment. Here's just some pictures to kind of see, again, focusing on quality care. These are things that are very doable across Africa. And the numbers that I think are the most important that people care about. So in 2018, we did an initial investment of $3 million to help ramp up for the COVID response in 2020. We did another $1 million investment. And already in 2020, we saw kind of huge annual revenue. Last year, we did 5.5 million in revenue, and this year we're expected to do 7.5 million in revenue. So I think just the numbers alone really speak to the opportunity that you have in primary care in Nigeria. We're set to look to expand across the country. That's really what our goal is. And so I think that you can kind of, from that, gauge what the actual revenue could be, as we grow. And I wanted to highlight, also in primary care, there's huge areas of opportunity for international partnerships, which is what people generally come to me to talk about. We have great partnerships with Siemens and Abbott. We also have great partnerships in the pharma industry with Novartis. But then even in other areas, like in energy efficiency with power companies, and then with the information technology companies as well, we use a lot of telemedicine support and technology in our primary care. And most of those companies are all based in Europe that provide that support to us. So that's another huge area for international companies to get involved in the primary care sector without necessarily, being a primary healthcare network. So just my kind of key takeaways about why I think you should invest in primary care. Again, Africa is the fastest growing healthcare market based on population growth. I do really emphasize that there is a private healthcare market in Africa that is investment ready. Maybe 10 years ago, this was much more challenging, but I do think that the COVID response and the focus on primary healthcare during the last year and a half has sparked a lot of really mature companies that are investment ready across Africa. And there are multiple areas within the primary care market even that you can invest in outside of just pharmaceuticals and manufacturing. But of course, pharmaceuticals is a great area. There are private primary care and hospitals. I know somebody else is going to talk about medical schools, which is a whole long conversation to talk about the training institutions that we need, and then of course medical devices. So that's my pitch. I hope I sold you on it.
Thank you so much, Evelyn. Several key take-home messages. We'll discuss it later during the Q&A session, but it is profitable. Very important, one. I have a question for you before moving to Githinji. Do you think that you can expand your model and make it as a continental model in a very short notice?
So our goal is just Nigeria. And, I think that to be successful, I don't think that we have to go outside of Nigeria. I think that Nigeria is our target market, and we're happy to stay here.
Thank you very much, Evelyn. Githinji, you're the man who knows very well the primary health system as well, but the entire ecosystem. And I have learned quite a lot, hearing you the past 3-4 years. So let's try to share with our investors all the attractivity of Africa.
Thanks, Karim, and thanks, Evelyn, for that case. And we have struggled a lot with provision of primary healthcare generally. Maybe just to reflect on why so in the continent. And if you looked at Evelyn's presentation, she did mention that Africa's population will continue to grow. Right now, Africa contributes about 17% of the global population, but unfortunately has only 2.7% of the global GDP, which is a major challenge. That number of 17% is likely to be 26% by the year 2050, meaning that Africa will be more than a quarter of the global population by 2050. The question is, with a 2.7% GDP, where is Africa going to be? In some estimates I saw from World Bank, it showed that even Africa was to grow its economy by 5% every year, and the rest of the world was to grow by 3%, it would take Africa 70 years to contribute 10% of the global GDP, meaning from 2.7 to 10%, would take 70 years with a 5% growth every year. So we already have an economic structural problem. And I think that's something we need to consider and ask ourselves, what do we need to do? And I think that, Karim, are more ecosystem macro issues like the Africa Continental Free Trade Area that needs to be resolved so that we can open up the market of 1.3 billion people. And in future, by 2050, 2.6 billion people, so that then they can have one common market. And I think that is really something we need to pack. It may not be the conversation now, but that's really the future, because if we don't do that, we continue with these small fragmented markets across the continent that can't even enable adequate manufacturing because, the movement of goods is not free, people and all that. So that's one area. But I also want to talk about what the result of this structural issue is. This structural issue of 1.17% of the population, of the world's population, and 2.7% of GDP, with a very informal economy, extremely informal. I would assume that in Nigeria, as is in Kenya, Uganda, and other countries, almost 80% of the economy is actually informal, which makes it very difficult to tax. And therefore, it means that whereas health is a public good, you cannot provide it because you don't get enough money from taxes. Africa's tax efficiency is about 13-14%. It's way up 35% and more in many of the OECD countries. So that brings a problem. Now, when you fix this, and I'll come back to this issue of primary healthcare and investability. If you want to calculate how much Africa can collect and then allocate to health, even if we followed the Abuja Declaration and all the primary healthcare principles, Africa may be able to collect maybe $50 a person only for health at full allocation of 15% of the country's total expenditure, 15% to health, and even increasing our tax efficiency to 20% from current 14, we'll end up with $50. Now, $50 is what the government then at maximum efficiency would be able to allocate to health, whereas the UK is allocating 4,000, the US is allocating 5,000. That's just public expenditure. I've not talked about the out-of-pocket or private expenditure. So you can see the challenge here. And we say, World Bank calculations, WHO indicate you need at least $86 to provide a basic primary healthcare package. So what is happening now in Africa with primary healthcare is actually we are spending the $86 per capita. But where is it coming from? When you remove the efficiency I talked about of 15% allocation and increased tax efficiency, and you take things as they are right now, the average would be about $30 per person from government. Some countries are even $7, $11 per person per year. So if you are to work with the $30 and you say we are still spending the 86, the balance of 56 is coming from donors and out-of-pocket expenditure. Now, this is where the challenge is, that if we do not have, if we continue having the financial difficulty for the majority of the people to actually access healthcare, then even private healthcare, models like the one of EHA will continue to be small and not scalable. So the issue I'm raising here is that for us to actually capacitate primary healthcare, and primary healthcare, when we talk about primary healthcare, we are saying it is actually what serves 80% of the needs of the population. It is where people work, live, and play. It is based on three basic, it's almost like the African stool, three-legged African stool, or what you may call the African kitchen with the three stones. It is multi-sectoral action, meaning all sectors together. It is primary care, which is what Evelyn is talking about, and it is community engagement and empowerment. To provide that, you need that ecosystem to come together. But then you need the answer to the question, who pays? I think that's the question. If I was to look at EHA's model and say the $5.5 million revenue, and I was to break that down, and maybe that's something that Evelyn can answer to us a little later, where does that money come from? It is possible that a lot of that money comes from people's pockets. But we know, and Dorothy may talk about this later, Karim, that the private sector insurance market in many countries is not more than 2% of the population. It is 2%. So the question is, if EHA is running on 2%, what about if EHA was run on 100% of the population of Nigeria? Where would it go? But how do you enable that? What's the journey to that? The journey to that is universal health coverage, is to ensure that everybody has access to some health insurance, whether paid for by government or contributed by the employer or themselves. And that is the journey to enabling EHA to access the 100% of the Nigerian market. In Kenya, we have National Health Insurance Fund. The National Health Insurance Fund spends $500 million payment every year on health. Now, where does the money come from? Comes from government, comes from companies who are paying for their employees, $500 million. But do you know where the majority of that money goes? $350 million go to private sector, meaning that actually, if you could actually improve the $500 million to more, to 4 or 5 times by ensuring everyone is a member of NHIF, then you can imagine the 350 going to private sector. How much would that be? So the focus should actually be, even as we create these service delivery mechanisms, we must also participate in changing the ecosystem, the policy, to push government towards universal health coverage, so that then private and public both thrive in a situation where there's equity for everybody. Back to you, Karen.
Thank you, Gideonji. I was not expecting from you a very quiet speech. I mean, so you challenged all of us, Evelyn, Dorothy. Dorothy, it's now. I mean, I will have from the start a question, because Gideonji opened up the stage. I mean, do you think that we can really create a kind of Netflix health insurance in Africa?
Karim, you're talking about Netflix insurance in Africa. now let me just start by saying this, and I'll twist that question a little bit, and I'll talk about the question on whether primary healthcare system can survive without the involvement of the private sector. And looking at and reflecting on this particular aspect, I'll give a very interesting answer. I'll give a combined answer of yes and no. Now, let me tell you why. So in Africa, in this particular region, it actually depends on the maturity of the healthcare system, of course, as well as the supporting health policies. So as you know, has been mentioned before, speaking specifically for Kenya, private sector takes, in terms of supporting, private sector supports more than about 40% of healthcare delivery in Kenya. Then we have faith-based organizations, which give in now the balance of about 30%. And then we have individuals who now end up having to pay out of pocket, end up having to look at ways of raising funds. So what we are basically saying in terms of the role of private sector, even though the government and the healthcare policies, as we've talked about, may support and are working towards supporting universal healthcare, as has been mentioned by, has been mentioned earlier, much of this money, most of these funds are actually coming back in terms of private health facilities. And at the end of the day, these two cannot work the private sector, for example, and now I'm heading into the insurance arm. The insurance side is supposed to be supporting whatever baseline support is provided by, universal healthcare policies. I look at the insurance penetration rate in Africa. We are at about 2.7%. Compare this to global rates of in excess of 7.3. Kenya has the lowest. In fact, in 2019, we dropped to the lowest penetration rate of 2.34%. Now, this is general insurance penetration. Now, when you go to medical, you're even at a worse off state. So, the aspect in terms of what private sector, what in specifically, insurance companies may be able to do to support, healthcare for the markets, of course, cannot be understated. Basic universal healthcare or primary healthcare will give, basic support. But then as private insurers, we come in to add the additional benefits or to give additional benefits that may still be very necessary, may not be, 100% mandatory at this point. But without that support, you end up having a community that struggles in the long run, struggles with chronic conditions, which may not be, picked early enough. And so we just have to really, really work together on this particular aspect.
So, thank you very much. So we have now a primary health system. We have all the figures and statistics shared by Gitinji. Insurance is doable, I think. Dorothy, I think we can. It is a tremendous opportunities for a financial investor. I mean, health insurance in Africa, I strongly believe in that. And now, just to achieve this universal health coverage 2030, we will need more than 12 million health workers in Africa. Razik, how can we train them? You're on mute, sir.
Hi, everyone. Thank you, Karim. Thank you for giving me this opportunity to tackle this very, very important problem, actually, all over the world, not only in Africa, but as you said, in Africa, we're talking that for a need and shortage of more than 10 million. Of course, this shortage has been really a problem, but the COVID has put under pressure all the system. And as you know, I think that the caregivers during the pandemic has really paid an important, they did a huge job, but also we lost a lot of caregivers because they have been in the front lines. And today we really need to consider that differently. The shortage, as you said, is huge. And it's kind of weird that we talk about unemployment in Africa. And when we also need more than 10 millions of caregivers. What's the problem? What's wrong? I think that the training doctors and nurses has been a public problem or issue and has not ever been tackled by private sector. Now we see that the healthcare is really important. Still before the COVID, we have been also trying to compress or really try to turn down all kind of investment in the healthcare, because as you said, truly it was a cost, but we know that without healthcare, there is no way to move forward. And healthcare is not a cost, is an investment. And when we talk about investment in healthcare, without caregivers, without healthcare workforce, we cannot develop any qualitative health. We talked about primary care. We talked about healthcare coverage. Of course, the healthcare workforce is the key. And as I said, there is unemployment in Africa, but still there is 10 million, more than 10 million needs in terms of healthcare workforce. How we can tackle this problem? I've been working in this sector, healthcare education, since for almost 10 years. And there is the new technologies that really have been very important. We launched our first medical simulation center in Tunisia in 2014. And in really a short time, we trained more than 7,000 healthcare workforce in Tunisia. Even during the COVID, we had worked on e-learning platforms in order to really make this healthcare force more ready to face the COVID situations. Now, as I said, there are a lot of new technologies, and investing in new technology will make, I won't say the training education easier, but more efficient. And we really talk about efficiency. We need to have more doctor. We talk in Africa about doctor deserts. Of course, we need to tackle that together. And I believe that if the private sector could really be an important actor in the sector, things will get really faster. I will give the example in Tunisia. There is an important UK actor that invested really hardly in the healthcare education sector, and I think that they're doing well in terms of business. And I hope that this kind of example will really lead more investment in Africa in terms of education. And of course, it isn't profitable, because when you propose to someone to invest even a little bit of money, so that after 3 or 5 years or 10 years he got really jobs, really well-paid jobs, he won't need to go to Europe to find jobs. So in Africa there is needs how we can together improve the education, how we can also not only in terms of quantitative but also in terms of qualitative, by using new technology and to really tackle this huge problem. Thank you, Karim.
Thank you, Ghazi. So new technologies. Dorothy, by the way, can we use new technologies in the insurance?
Yes. And I was really hoping that you'd ask me the question on digital. So the evolving digital space provides a great opportunity. And as you know, specifically even for diagnosis, their miniaturization of diagnostic equipment, we now have digital thermometers, complicated tests that, would need a big lab somewhere with, these huge machines can now be done from anywhere now that they are more portable, they are smaller. Now, what does this do to the digital market? And especially from, the healthcare, insurance and healthcare management perspective, this makes care now more available. It works well. And especially, in Africa, as you know, let me give specific examples in Kenya. Kenya has one of the highest mobile penetration rates. We're actually at 109%, meaning, we have individuals who have more than one SIM card. We have an internet penetration rate of about 40%. So we are seeing a lot of, investment coming through in terms of, digital healthcare apps, digital ways of rolling out, digital financing for health, digital insurance related to health. And there's a lot in the market, actually, possibly in terms of the space in technology where, and the insurance where there's a lot of activity. It's actually in the medical insurance space. And why is this? Because it works well for data. It works well for portability, allowing a client, an insurance client, to be served and from one facility and be able to be referred from one place to the other seamlessly with the data being moved. We now have apps that are, what we've seen in external markets now being, implemented here, where now you have apps that are almost forming a seamless value chain in terms of from the medical services providers, these are the hospitals, to the chemists or the pharmacies, linking directly to the insurance companies, of course, linking to the clients or the patients in this particular case. So it's making the entire value chain work better. There's also an element of cost, and from an underwriter's or an insurer's perspective, of course, with the reduction on administration costs, there's not too much paperwork being moved around. Patients or customers, of course, from the insurance point of view, they are customers, and then of course, when they're being served, they end up becoming patients. So the customers are being onboarded at a faster rate. They're able to be provided the care they need at the touch of the button from their phones. We also have, apps that are now even able to track the activity. Of course, not as developed as we would want it, or as we'd want it, as we've seen in external markets, but there's a great level of activity. Now, why do I say there's great opportunity in Kenya? For example, medical insurance is actually second in terms of the gross written premiums, just after motor. And so that means, even from those who are seeking private healthcare, many of them, are coming to the insurers. And so from an investments perspective, from a digital perspective, healthcare in Kenya is a go-to place. Of course, supported, like I mentioned, with the high mobile penetration rate and the internet penetration rate and stability that we are seeing in our infrastructure that is able to support this. I think the question would come in terms of, does digital and, for example, micro provide full coverage? Coverage that would be necessary or coverage that would be adequate? I want to say that in most cases, yes. It depends on the digital providers, and there are a number of them, you can see them online, who are actually doing a lot in this particular space, and specifically in Kenya.
Oh, that's great, Dorothy. So we have a solution, and it's
Yes.
an investment opportunity. Very good. Gitinji, I have a question for you. This is a bit a sensitive question. Today, we convinced our attendees that they can invest in health in Africa. First, it's profitable. Second, they have to do it. My question is, do you think that according to the lessons learned from the COVID-19, the head of states will invest more money in health in Africa, or they will keep this small ratio of 2 to 3%, this average of 2 to 3% investment in health? Do you think that in the budget of 2022, we will see more money invested in health because they have seen the economy collapsing because of health?
Thanks, Karim. This is a really important question. And I'll go back to the numbers I gave, that the economies, to start with, are very tiny. So if you looked at Kenya specifically, if I were just to give you examples of Kenya, currently we invest about 7% of the total government expenditure on health, 7%. We are looking to go to 15%, of course, the Abuja, but we are now currently investing 5%. The competing sector is education. That's where the competing sector is. It's actually education. Because the government spends about 35% of its general expenditure on education. And their general arguments are that an educated population is a healthier population. So there is these competing ideologies around where to take health monies. But let us for once assume that the government has seen the need, and they have seen the need that really the real bulletproof for the economy is healthy populations, is health. And therefore the government may decide, okay, we are going to put in more money. Now, that would mean that if Kenya, for example, doubled, which is not going to be possible, definitely, even if Kenya doubled its current expenditure on health, it will move from $30 to $60 per person. So we would have more money, but still nowhere near where we need to be. But maybe specifically to your question, that economies, for the first time, we've seen the economy of Kenya has contracted for the first time since 1992. For the first time, we're actually getting negative growth in 2020. Negative 0.3, I think, is what is projected for 2021. For 2020, and then 2021, we may get probably minimal growth. So even when you think around increasing money, the fiscal space or the available resources to do that is minimal. So this is a real issue. So I think what we need to do is to think around how to increase participation of people who can actually afford to pay for insurance to get into the pooling mechanism. I think that's what we need to do. The government increment may be positive, but what about, Dorothy talked about 2%, but then you have another 20% with NHIF, which is mandatory by employment. Then in between here, you have 78% people who are not contributing to any form of insurance. Now, out of that 78%, not all the 78% are indigent. Maybe out of that, only 35% or so are indigent. So how do you make these other 40% actually also contribute to the health sector, so that we are not only looking at government, and we need to look at mechanisms to mandate these contributions? I mean, in many countries, in all countries in Africa, I would assume that motor vehicle insurance is mandatory. And that is why, as Dorothy said, motor vehicle insurance is the highest revenue premium, followed by health. But motor vehicle, you have no choice. You have to invest your car, you have to invest your motorcycle. Even somebody with a motorcycle who can't afford a car, they have to insure it, at least a minimum third party. And third party for a car is $70 a year. So it's significant. That $70 that you use to invest your car is actually what NHIF charges. It's actually more than what the National Health Insurance charges. It charges $60 per year, but it's not mandated. Therefore, we need to look at government, but we need to look at crowdsourcing and blended financing for health sector, so the government, even as we push them to increase, is not the only source of money to make sure that there is a proper investment in healthcare.
Thank you so much, Gitinji. Very good clarification. My last question will go to Evelyn. Evelyn, after hearing and listening to Dorothy and Gitinji and Ghazi, are you more optimistic or less optimistic about what you are doing in this such a rough and tough sector, which is the primary health care system? I mean,
so I think it's a little bit of like a chicken and an egg type situation, because in order for insurance to work, there has to be a functioning primary care, network in the country. And so I do feel like in order for, I could go on for like a long time about this topic, but one of the main reasons why we started EHA clinics in the first place was because the insurance system that we were paying for was failing us, and not because it was just because there were no quality facilities that we could send our staff to, even though we were paying for insurance. And so you can't have one without the other. And so hopefully, as we invest in both areas, we can see them both be successful.
Thank you, Evelyn. So I think we reached the end of this session. My feeling is that we have a lot of positive energy behind the health sector in Africa. And it's not only just a kind of health optimism, but it's also a reality. Things are moving on. Everything is on the way. So my recommendation today, invest your money in health in Africa. You will have, I think, a very, very interesting return on investment. Thank you to the great panelists, and looking forward to meeting you again around the globe. Bye-bye.
Thank you and bye-bye.
Bye, Karim. Bye, Karim. Bye.
Bye-bye.